My name is Chris Upton, and I am a faculty member at the Hendersonville Family Medicine Residency in Hendersonville, North Carolina. This video is to discuss indications for late preterm and early term deliveries. A few things I'd like to mention first. Number one, twin pregnancies will not be discussed in this video, as they are likely out of the scope of practice for the general family physician and should be taken care of in consultation with a high-risk obstetrics provider. Two, the timing of delivery is highly variable based on your MFM recommendations and your locality, and so even the most concrete numbers that I discussed today may change based on your consultations. I would like to start by talking about 34-week indications for delivery. Pre-eclampsia with severe features should be delivered at 34 weeks if they have not already been delivered by that time. The same is true for PPROM, or preterm premature rupture of membranes. They should be delivered at 34 weeks if they have not been delivered prior to that for other complicating factors. Placenta Previa with a concern for accreta should be delivered around 34 weeks. Of note, any placenta previa with concern for accreta should be cared for with the consultation of an OB/GYN provider and likely an MFM specialist as well. Moving forward to 37 weeks, preeclampsia without severe features is an indication for delivery at 37 weeks. Gestational hypertension is also an indication for delivery at 37 weeks. Placenta previa should be delivered by cesarean section at 37 weeks. Oligohydramnios should be delivered at 37 weeks or thereafter once discovered. If it is discovered before 37 weeks, then the care should be individualized based on recommendations from your local OB/GYN or MFM provider. Any woman with a prior classical cesarean section or a myomectomy in her history should be delivered by cesarean section at 37 weeks. It is up to the provider to determine whether fetal lung maturity should be tested prior to delivery. The following topics have a broad range of timing of delivery. The timing of induction for these patients should be based upon maternal and fetal health and the recommendations of your high-risk providers. The first category is growth restriction. The growth-restricted fetus should be delivered between 38 and 40 weeks. However, this may change based on other factors complicating the pregnancy, including oligohydramnios or non-reassuring Dopplers, including reverse end diastolic flow. The second category, chronic hypertension, has a broad range of timing of induction from 36 weeks to 40 weeks. The decision to induce is based mainly on how difficult it is to control the blood pressure of the patient. Chronic hypertension that is difficult to control may be induced as early as 36 weeks. The timing of delivery for patients with chronic hypertension controlled on medications or off medications is 37 weeks to 40 weeks gestation. The last major category is diabetes. This can be broken down into pregestational diabetes and gestational diabetes. For pregestational diabetics whose sugars are well controlled, there is no indication for late preterm or early term delivery. For pre-existing diabetics with poorly controlled blood sugars, timing of delivery is between 34 and 39 weeks gestation. The exact timing of delivery is based on considerations including maternal and fetal health and monitoring, and any recommendations from your local high-risk obstetrics provider. These patients are likely out of the scope for the family physician unless there is collaboration with a high-risk obstetrics provider. Gestational diabetics who are well controlled on diet or medications, there is no indication for delivery in the late preterm or early term stages. Gestational diabetics with poorly controlled blood sugars should be delivered between 34 and 39 weeks gestation. Once again, the exact timing of delivery is based on considerations including maternal and fetal well-being and other monitoring parameters. For instance, if there is any concern for fetal well-being and maternal blood sugars are poorly controlled, these patients should be delivered as early as safely possible. Regarding post-dates induction, 41 weeks is still the standard. However, there is now some data showing that 39-week inductions may have some benefits for the mom and the infant. Only time will tell if this leads to a lasting change in standard of practice for OB/GYN and family medicine physicians practicing obstetrics. Another scenario to discuss is timing of delivery for a patient who had had a stillbirth in a prior pregnancy. Common practice is to induce these patients at 39 weeks gestation. However, there is no evidence to back up this practice, and patients may elect to proceed to 40 or 41 weeks, provided good fetal monitoring throughout. The reason the majority of providers choose to induce at 39 weeks is to attempt to minimize patient anxiety. Thank you for watching this video, which is part of the Black Bag series from the Hendersonville Family Medicine Residency.